So I'd like to welcome our first speakers for this session, Dr. Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota, who will present on risk stratification for plasma cell disorders. So please welcome Vincent.
Hi, everyone. Thank you for inviting me again, Brian. It's always a pleasure to be back here. Unlike what you might hear from the other speakers, which might not be possible right now in your country, what I'm going to talk about is probably going to be immediately applicable, like right now you can do it. So that's good. Where are my questions? Can we go ahead with the questions first? Okay. I have 3 questions to start off with. So we'll start with the first patient that I'm talking about, which is a 54-year-old man found to have elevated monoclonal protein. Monoclonal spike is 1.9 IgG kappa. Additional workup shows that the serum free kappa is 5.0, serum free lambda is 1.0, CBC, calcium, creatinine are normal. What would you recommend next? Bone marrow biopsy, bone imaging, bone marrow biopsy and bone imaging, bone marrow biopsy, bone imaging, and whole body MRI, bone marrow biopsy and whole body MRI, or uncertain? Go ahead and vote. Okay, so 45% of you chose bone marrow biopsy and bone imaging. And let's see what the next choice is. That's actually what the faculty also picked. So very good. And we'll go ahead with, while I present the discussion, why that's the right answer. So this patient undergoes the bone marrow biopsy, which shows 8% plasma cells, and the bone imaging, which is negative. So probably MGUS. Patients watched annually for 3 years. And now in 2018, the patient presents with an increase in monoclonal protein to 2.5 grams, but still no symptoms. CBC, calcium, creatinine are normal, and we repeat the bone marrow biopsy because the M spike has gone up, and that shows 25% plasma cells. Oops, sorry, can you go back to the question? So please read the question very carefully. There's some trick question. Go back to the question again. Yep. Which of the following is not consistent with high-risk smoldering myeloma in this patient that we just heard? A free light chain ratio if it came back more than 25, 414 translocation. If the MRI showed 3 focal lesions, 8 to 10 millimeters in size. If the FISH showed deletion 17p or uncertain. Which of this is not consistent with high-risk smoldering multiple myeloma? Please vote. Okay. So we have 2 groups that are dominating, 38% for free light chain and then 40% for the 3 focal lesions. So let's see how the faculty voted. Okay, so the correct answer is 3 or more focal lesions on the MRI. 3 focal lesions on MRI makes the patient has multiple myeloma, not smoldering multiple myeloma. So we'll talk about that as well. Oops. Can you go back to the question again? Yeah. So let's say this patient is myeloma and a few years pass, we've diagnosed the patient as myeloma. Which of the following in a myeloma patient will indicate standard risk disease? DEL17, trisomy 3, 5, 9, 15, 4, 14, 14, 16, gain 1q or unsure. Which of these abnormalities suggests standard risk disease? Please vote. Great. Almost everyone got this right. Well, not quite. 1/3 got some other answer. 70% got it right, which I hope. And then the second step is over a course of time, 1% of patients each year get something else. It could be a del17, it could be a 1q gain, it could be any number of different things which we are still not sure of, RAS mutations, MYC translocations. And that causes the MGUS, which is like a polyp, to become multiple myeloma analogous to colon cancer. And then once myeloma happens, over the course of a myeloma patient's lifetime, additional abnormalities happen, which can then make the myeloma more and more refractory as time goes by, and eventually the patient succumbs to the disease. The first things first, diagnostic criteria. In 2014, the International Myeloma Working Group changed the diagnostic criteria for MGUS, smoldering multiple myeloma, and multiple myeloma. And I want everybody to be on the exact same page in terms of what constitutes each of these three disorders. The first thing is to remember that smoldering multiple myeloma and MGUS are characterized or defined by absence of myeloma-defining events, whereas myeloma requires the presence of myeloma-defining events. That's the main way in which we split myeloma from MGUS and smoldering. And then we split patients who have a plasma cell disorder who don't have a myeloma-defining event into two groups, MGUS and smoldering myeloma. Why do we do that? Because MGUS has a risk of progression of only 1% per year, but smoldering myeloma has a risk of progression of 10% per year. So we split them into two groups based simply on the proportion of plasma cells in the bone marrow, less than 10% for MGUS, and the size of the monoclonal protein, less than 3 grams versus 3 grams or more. So if a patient has either more than 10% clonal plasma cells or more than 3 grams M protein, and no myeloma defining event, that becomes smoldering multiple myeloma. Myeloma itself is defined as the presence of myeloma defining events in a patient who has a known clonal plasma cell disorder. Now, the clonal plasma cell disorder may be more than 10% bone marrow plasma cells or a biopsy-proven plasmacytoma, and then you have one or more myeloma-defining events, which includes your traditional CRAB features, hypercalcemia, renal failure, anemia, bone lesions, as well as 3 biomarkers that we added, which is if the bone marrow plasma cell percentage is 60 or more, that's automatically myeloma with or without CRAB, free light chain ratio more than 100, or more than 1 focal lesion on MRI. So this patient that we had in the case with 3 focal lesions, which were beyond the 5 millimeter cutoff size, is automatically myeloma, not high-risk smoldering myeloma, and that's why that answer was correct. Now let's start with MGUS. MGUS itself is classified into 3 different kinds of MGUS, and the reason we split it is because the type of problem that an MGUS patient will progress to is different based on the type of MGUS. So there are 3 types of MGUS. One is the non-IgM, that includes IgA, IgG MGUS, the IgM MGUS, and light chain MGUS. IgM MGUS most of the time progresses to Waldenstrom's macroglobulinemia. Non-IgM and light chain MGUS progress to myeloma. There is some differences in the risk of progression of these disorders. In general, IgM has the highest risk, non-IgM second, and light chain MGUS, the way we define it right now, probably has a lower risk of progression than non-IgM MGUS. This slide is very important, and I want you to keep this in mind. Many MGUS patients who see you, you might be the only physician that they see once a year, even though you're a hematologist. And what you need to remember is that the actual risk of dying from multiple myeloma or progressing to multiple myeloma, amyloid, Waldenstrom's macroglobulinemia, or one of those plasma cell disorders is still quite low. It's only about 10% of all MGUS patients who will have this kind of problem. 90% of them will die of something else, non-related to the myeloma or amyloid or plasma cell disorder progression. So we need to make sure that we don't forget to monitor them for breast cancer, colon cancer, prostate cancer, heart disease, cholesterol, everything else that's important and not focus only on the plasma cell progression part, because that risk is still low compared to the relative probability of dying from other things. This is from a classic paper that Bob Kyle published in the New England Journal of Medicine this year. Now, once you know the patient has MGUS, simply using the M spike size, the IgG type, and the free light chain ratio, you can divide this into 3 different groups. Patients who have all 3 abnormal, that means more than 1 gram, 1.5 grams M spike, and non-IgG type and abnormal light chain ratio, will have a higher risk than patients who have everything normal. When you work up a patient with MGUS, if the patient looks like a low-risk MGUS, a small IgG MGUS with a normal light chain ratio, or a small IgM MGUS, or a very small light chain MGUS, and there are no complications, it's uncomplicated, then you don't need to do a baseline bone marrow biopsy and a bone survey. You can assume these will classify a patient with smoldering myeloma as high risk. Patients with very high M spikes, patients with high light chain ratios, that's not quite 100, but very high nevertheless. Abnormalities like deletion 17p, 414, or gain 1q. An evolving pattern, like the M spike continues to rise, or increase in circulating plasma cells. Here is a new risk stratification system that was proposed as the Mayo 22. Patients who have a bone marrow plasma cell percentage more than 20%, M protein more than 2 grams, and free light chain more than 20 for the ratio. You can see here, if all 3 are abnormal, you have a much higher risk of progression than if nothing is abnormal. How do we potentially smoldering myeloma or multiple myeloma? If the patient has Crab features or one of the other myeloma defining events, we are going to label them as having myeloma and treat them. If they have no myeloma defining events, they are considered as smoldering myeloma. And if the patient is low risk, that means absence of all the high risk features that I listed, then those patients, everyone is comfortable with just observation. We just watch them every 3 to 4 months. The high risk smoldering myeloma, right now there's a high interest in clinical trials for this population because these patients are at 50% risk of progression within 2 years. So in these patients, a number of clinical trials are available, and we encourage the patients to be put on them. The gray area is patients who have multiple high-risk factors who are smoldering, who are so-called smoldering, but they have multiple high-risk factors. Or if the M spike is rising as you are following them, but they still don't meet the criteria for myeloma. That's a gray area. And I think based on the Spanish trial, some of us will consider treating a few of these patients as multiple myeloma. I told you there are a number of clinical trials going on in smoldering myeloma. One of them is a strategy of just getting drugs approved. That will be trials such as lenalidomide versus observation or DARA versus observation. Some of this is a strategic trial where we are trying to improve the outcome of smoldering myeloma by doing more intensive therapy to try and see if we can prolong overall survival of patients. And most exciting is that there are some trials such as the Caesar trial, which is done in Spain, and the Ascent trial, which is led by Dr. Rajkumar, which are really going all out to see if we treat patients with smoldering myeloma at an early stage before they have symptoms, is it potentially possible to cure myeloma? So there are all 3 types of trials going on. All of us are doing all of these 3 types. It doesn't mean we favor one type or the other. We just think we need research in the high-risk treatment, high-risk smoldering myeloma patients to improve outcome. Which of these 3 approaches will be successful, time will tell. Finally, I'll close with multiple myeloma, and I won't get into the treatment of this disease, but mainly the risk stratification. We have a paper this year that Dr. Kumar and I wrote calling it multiple myelomas. It's just like there are many, many types of lymphomas. We don't call it just lymphoma and have a lecture on that. But myeloma is much rarer, and therefore we pooled a number of different diseases and we are calling them myeloma, but it's really 6 different diseases at the minimum. Where's the next slide? There you go. There are 6 different diseases that are basically called as myeloma. There are more than 6, but these 6 are the big ones. And this includes about 40-45% of patients who have trisomic type of myeloma. They have extra odd numbered chromosomes. And then some who have translocations involving 1114 or 614 or one of these other translocations. Each of these are considered a primary cytogenetic abnormality. And the complicating thing in myeloma is that any one of these 6 types can then get a secondary cytogenetic abnormality, which then affects the outcome even further. So for example, you can have a 414 myeloma, which then gets a deletion 17p on top of it. And that makes myeloma a little bit more complicated than many other diseases that we deal with. Here's a simple slide for cytogenetic risk stratification of myeloma. You can see that the disease aggressiveness goes as you go from trisomies to 11, 14, 614 to the 414, 14, 16, 14, 20, which have the highest risk. So the disease aggressiveness goes up. Any of these can then get deletion 17p or p53 mutations or gain 1q, and the disease aggressiveness goes up with the acquisition of these secondary abnormalities as well. Now when you get more than one of these, so if you have a 414 and a deletion 17p, that's worse than having either one alone, and that will be like a double hit myeloma. And if you have 3 or more high risk abnormalities, the risk of the prognosis is even worse, and so that's triple hit myeloma. The revised international staging system takes the cytogenetics that I just talked about and adds to it some other prognostic factors that we know quite well. That's beta-2 microglobulin, LDH, and albumin. Puts the high-risk cytogenetics, everything together. I don't want you to memorize this, but simply know that the revised international staging system takes all of these things and puts them together and divides myeloma into 3 different groups. And each group is associated with a different prognosis. So the revised international staging system is what we are currently using in clinical trials for risk stratification. I'll close with plasma cell leukemia, which is an odd entity, but just so you know that when you have more than 5% plasma cells in the circulation on a regular CBC, that is associated with an outcome that is much worse than even high-risk myeloma. Now, ordinarily, we call only more than 20% plasma cells as plasma cell leukemia, but our studies now, there are 3 studies which show that even 5% circulating plasma cells on a regular CBC is really more aggressive than even the high-risk myelomas. So in summary, we have in myeloma a new diagnostic criteria which was introduced in 2014. We have a molecular classification based on primary cytogenetic abnormalities that divide myeloma into at least 6 types. We have a new risk stratification system for myeloma called the Revised International Staging System. Similarly, there is a risk stratification system, the 2-20-20 for smoldering, and the MGUS based on a light chain ratio and M spike that I talked about, and the RISS. Thanks so much for your attention, and that's all I have.
So thank you so much, Vincent, for that comprehensive overview of the early disease diagnostic and treatment implications. First of all, any comments or questions from the panel? Jesus?
Yeah, I have a comment. First of all, I mean, I really enjoy very, very good talk. But regarding IgM, monoclonal gammopathy, in my current practice, I tend to do a bone marrow in these patients because with a small spike, they may have either lymphoma or Waldenström macroglobulinemia. And just to have the correct diagnosis is my current practice. What do you think about it?
Again, you know, I use the word uncomplicated. So if the patient, what I struggle with is if a patient with has a 0.5 IgM and the hemoglobin is 15, do I really think that the patient could have a lymphoplasmacytic lymphoma? And if so, would I really treat?
Okay. So I actually have a similar question. In patients with MGUS who have numbers which are close to the 1.5 or the 8, do you have a different strategy to make sure if they have low-risk MGUS or maybe something more advanced where a bone marrow might be required? Because this is a discriminator to do that bone marrow test.
So the answer is, like, anytime you think that something is not right, do a bone marrow. Anytime you think something is not right, do a bone survey. If you're very comfortable that, the CBC is 100% normal, the calcium creatinine are normal, and the M spike is small, if it's 1.4 and you're uncomfortable, do it. But if you're totally comfortable because it's smaller than that, or if it's only a fixed positive MGUS, there are 5% of patients in the world who have a monoclonal gammopathy if we define it the way we do. That's millions of people. I don't want to put millions of people into a bone marrow bone survey if the yield is extraordinarily low. They did a study in Italy where they said, suppose we did a bone marrow on all of these patients and a bone survey on all of these patients. How many smoldering myeloma would we find? They found 2%. So yeah, I'll be wrong 2% of the time, but I will know within 6 months if I was wrong, because I'm going to repeat the test, and if it's gone up, I would always do it. So you can, resource-wise, save a lot of resources, and discomfort-wise, spare your patients a lot of agony by being a more risk-adaptive approach to these two tests, which I think are quite expensive and or invasive.
Yeah, so perhaps a little bit more careful follow-up initially, just to be more certain. So do we have any questions from the audience?
Could I ask about...
There's a microphone coming. There you go.
No,
It's working.
My name's Tony Blau. I'm wondering about amyloidosis. So M spike, and even if I'm not worried about it progressing necessarily to, smoldering or active myeloma, it'd be great to pick up amyloidosis before symptoms kick in.
Right.
And what are you thinking? What's your thought?
So I think a good question. So what do you think about being cautious about possible amyloid, Vincent?
Absolutely excellent question. In general, when we are following MGUS patients, we are just checking only CBC, calcium, creatinine, and symptoms. Dr. Gertz, Dr. Dispenzieri have raised the question, should we be checking at least an NT-proBNP so that we can capture some cardiac amyloid ahead of time? And it's a simple lab test, so if it's feasible, I'm okay with that. Most of the time with amyloid, you will have some symptoms, but if your question is, can we catch them ahead of time? So patients who have an abnormal light chain ratio, who are the ones who are likely to get amyloid, it would be reasonable, at least for the NT-proBNP.
If there's any renal involvement, you would have picked it up. At least there are two organs you're going to be checking.
Okay, time for maybe one or two more questions. Yeah, go ahead.
Yes, as part of the criteria, you mentioned normal free light chain ratio. For people with pre-existing renal dysfunction, it's not quite clear what normal values we should use. There have been a few papers published on the varying normals for renal failure. Can you comment on that? Or would you do a bone marrow in anybody who's got pre-existing renal failure for, known for other reasons?
Yes.
Correct. This is a great question on the light chain ratio in terms of what is normal. For MGUS, since simply we are saying is the light chain ratio normal or abnormal, that does pose a problem, because when we did the study years ago, it was 2005. Since then, we have learned that at least the binding site free light chain assay, which has a free light chain ratio of 0.26 to 1.65 as the normal range, may be too narrow, particularly on ratios going up. So I would say there's some wiggle room there. Up to 4, I'm okay with calling it as a normal light chain ratio. In smoldering myeloma and myeloma, that problem doesn't arise because you're talking much more extreme levels, like with the 20 to 20 criteria, more than 20 for the free light chain ratio will be high risk. And for myeloma, more than 100 will be high risk. Those levels you won't reach with renal failure alone.
All right, thanks
Amira?
for that. So we have one over here. Yes, please, go ahead.
My question is risk, but it was only 80 patients in the poster on this session, and it's not high risk, I think. 19 months, and I think it should be revised.
You want to comment on this? I think.
Hervé Avelloiseau on behalf
Yes.
Hervé Avelloiseau on behalf of the French 1416, and we did confirm that we didn't have, in fact, this adverse prognosis. But Vincent, years as well.
All right. Is it high risk?
1416 currently is considered high risk, and I will continue to consider it high risk until somebody shows me a study. The problem with any prognostic factor study is it depends on which setting you're doing it in. So for example, 1416 is one of those translocations that leads to extraordinarily high light chain levels and a higher risk of renal failure. So if you have a trial where systematically the prognostic effect of the 1416 is lost compared to standard risk. So Dr. Kumar has done all patients, and you look at trisomies 11, 14, 14, 16, 4, 14, del 17, 1q.
Yeah.
It has to be very clear you use the patients or select the patients right from diagnosis, because if they have already survived a year or two.
Bias there. Quick questions.
And peripheral neuropathy. To work up for M and
ADS. And this neuropathy usually starts with the toes and then progresses. And if there is no other cause, it's possibly related to the MGUS itself. And we usually can those present like Guillain-Barré syndrome with both proximal and distal involvement. And those are treated basically like any other CIDP or not.
All right. We should.
One last question. So I wanted to just get your that's been recently published on the free light chain prediction of whether or not that's going to actually progress to myeloma within 48 months or
The 100.
So again, I can only go by the data that we generated. As Dr. Kumar pointed out, the study has to be agnostic. 150 for the last 5 years, and you then that will not be 70-80%.
Conduct. Okay, it didn't go to the, and the case continues with evidence of progression, and the questions are not coming up. I guess we are going to go and we're going to answer this third one, hopefully. So this third question was, which of the following are not consistent with high-risk smoldering myeloma? And so you did answer this one before. Okay, why, gosh. Vincent. All right, very good.
I'm only looking at that blue. Who is the blue?
What is that? Oh. I don't know.